think you all are fine, safe and sound. Dr. Fazlibadi. Today I discuss about the short case of some diseases and medicine related medicine. And first I will discuss about the GIT short cases. GIT short cases. The common short case of GIT are like ascites, hepatomegaly, splenomegaly, lumps. These are the common cases usually found in the world, and you have to know about the clinical examinations and how to interpret the clinical diagnosis. Actually, teachers or examiner want to know about your skills. In the short case, want to know about your skills and how will you interpret the case and your findings. No, when you are in the examination board, you have some instructions, and accordingly, you should proceed your examination, clinical examination, and describe your findings, both positive findings and if there is any negative findings, important negative findings. And all examinations have some parts. These are inspection, palpation, percussion, and auscultation. And if there is instruction, examine the abdomen or examine the chest from front. You should do all the examination, including inspection, palpation, percussion, auscultation. Or your examiner may give you instruction, please palpate the abdomen or please percuss the abdomen or anything else. You should do to the point what the examiner wants or what the examination asked for. But if there is instruction examine the case, then you should do inspection, palpation, percussion, auscultation, all. And then you should tell the findings. Earlier I say every short case, it is the basic. You should know the what you want to do and what are you going to do. That is, obey the instruction, examine accordingly, and then tell the findings. And then examiner will guide you the what you should answer according to question of the examiner. You will proceed your examination. Like অনেক সময় sometimes you see forget to see the patients and see the shifting dullness during abdominal examination. You forget to do the shifting dullness. Please don't forget to do it. There is sideline. This is the position. Position is very important. Position is very important. When asked for the examination, you should do the position of the patients. Now, common questions asked about the ascites. Then, what is ascites? Why it is ascites? How will you confirm clinically ascites? How will you confirm? It is by detecting the shifting dullness and fluid thrill. What is ascites? It is a accumulation of free fluid within the abdominal cavity. It is the free fluid within the abdominal cavity or pleural cavity. Sorry, peritoneal cavity. As it is free, so it gives the shifting dullness, gives the fluid thrill, shifting dullness. So, as it is, how will you confirm? Clinically, shifting dullness and fluid thrill. Like another question, how will you confirm ascites? If say how will you confirm, then you should answer it. Clinically, I will do the shifting dullness and the fluid thrill, so it is ascites. And to confirm it, I want to do aspiration of the peritoneal fluid or ultrasonogram. Ultrasonogram also confirm fluid in the peritoneum. What are the common cause of ascites? Common cause of ascites. Pinpoint the answer. Only the common causes. And if examiner wants to know more, you should proceed the further the causes. There is many causes, but you should utter the common causes of ascites. Like CLD. CLD is a common cause of ascites. Like peritoneal tuberculosis. Secondaries in the peritoneum. Any secondaries in the peritoneum. Nephrotic syndrome. CCF. Congestive cardiac failure. These are the common cause of ascites. But if you tell first that is the Meek syndrome is the first, then you will be asked so many questions by the examiners. So always try to present the answer simple and easy way, simple and easy way, and common causes first. Then what will you want to ask to find out the possible cause of ascites? There is so many causes of ascites, but the common cause are CLD with portal hypertension, congestive cardiac failure, nephrotic syndrome. This is more common, and we can differentiate it with by clinical presentation of the case. So you should ask the patient. Then you say, sir, I want to ask the patient first which one appears. If the edema first appear in the face, there is possibility of nephrotic syndrome. If first in the abdomen, then the possibility is in the CLD. And if dependent edema first, then it may be CCF. Then when you examine the patient and say that the CLD, it is a ascites, and then sir may go, what would be the cause of this ascites? You answer that it is CLD. Then sir may ask you why it is not congestive cardiac failure, why it is not nephrotic syndrome. The answer is I want to ask, and this it is CLD. If it is first appear in the abdomen, it is dependent nephrotic syndrome. If face. Second one, if it is CLD, because in palpation I found splenomegaly, and I also want to see the other findings of the CLD. And why it is not CCF? The CCF, there is ascites with tender liver, but I did not found any tender liver. Nephrotic syndrome, it is a generalized edema. I want to see leg edema, I want to see here, and also history. And if it is CCF, what would you like to examine next? I want to examine next the congestive uh, raised JVB. Is it? It is palpable raised, pulsatile raised JVP. Then pulsatile, is there any cause where the JVP is not raised but not pulsated? Yes. What is the cause? It is supraventricular obstruction. So this is how a examination proceeds. You should do the examination in a short time, and if you answer the question straightforward and appropriate answer, the examination will be ended very quickly with a successful ending. Now, what relative examination you want to do? I already discussed. How will you correlate the examination clinical findings with your diagnosis? Now, what investigation you want to do to reach a diagnosis? Reach a diagnosis is if you think it is a CLD, then you should go for the liver function test. Then you should go for the peritoneal fluid or ascitic fluid study. It will help you the causes of other causes of ascites, other causes of ascites. Broadly, you know that this ascitic fluid or pleural fluid also, there are two types. One is exudative type and another was transudative type. Exudative fluid and transudative fluid. Where the permeability increase, protein-rich fluid within the ascites and cell debris, so it become protein-rich fluid and it is called exudative fluid. Usually inflammation of the peritoneum, like tubercular peritonitis, knee peritonitis, secondaries in the peritoneum. This is pancreatitis. These are the cause of exudative fluid in the ascitic fluid, exudative fluid, and transudative, where the hydrostatic pressure increased, then shift of the fluid in the cavity. It is CCF, any portal hypertension, nephrotic syndrome, portal hypertension, CCF. These are the cause of transudative cause of transudative fluid in the peritoneal cavity. But another thing is SAG. You should remember SAG because the previous definition about the exudative and transudative is not give sensitive information about the cause, but SAG give sensitive information about your diagnosis or cause. And in case of portal hypertension, sealed with portal hypertension, it will give more than 97% sensitivity, 97% prediction করবে হচ্ছে cause is CLD. So SAG is very important nowadays. What is SAG? SAG is the serum albumin to ascitic serum to ascitic albumin gradient. Albumin gradient. It is the principle that the hydrostatic pressure leaks the fluid, leaving the proteins inside intravascular. Or the vessel inside the vessel, the protein inside the vessel not pass through the semi-permeable membranes. So this gradient and the fluid comes, but protein trapped in the within the vessels, as it is larger, as it is larger in molecular diameters. So this is the principle hydrostatic pressure. And the sag, this gradient, if it is this gradient is less, the cause is the cause is uh, inflammations like tuberculosis, carcinoma, pancreatitis, like that. And if it is high, sag gradient is high, then it is portal hypertension or CCF. This is the albumin more in the plasma and less in the acidic fluid. The gradient will be increased and the cause will be portal hypertension. Portal hypertension due to any cause, maybe CLD, maybe Butcher syndrome, or portal vein thrombosis, any cause. Portal hypertension, which increase the system, increase the local system or hydrostatic pressure. Now, how ascites develop in CLD? CLD, how ascites is developed. There is pathology, you also know. I don't want to discuss it now. You already know what are there is four pathologies, how the ascites develops. And important thing is in ascites, the spleen is palpable or not, the liver is tender or not, is there any liver or spleen present? Okay. Now, hepatomegaly, you all know about the hepatomegaly is very important, very important. You may ask questions from ascites also, abdominal, any abdominal examination, from any abdominal examination you must, what are the cause of hepatomegaly? It is very common question and you should know the cause. And again, instruction, follow the instruction. If your examiner, if the examiner asked, please palpate the abdomen, you should inspect the abdomen, but you should do the palpation only. And after that, if you want to examine anything else, then you may ask the ask your sir, your examiner, sir, I want to see the lymph nodes, neck lymph nodes, or anything other parts, lymph nodes of the other parts, or I want to know the anemia, is there is anemia or jaundice, etc. Okay, but when say palpate, you should palpate the, and it needs skill. It needs skill which is not a, which is not you find by taking only by reading only. You should come in the word and you should see the patient regularly, then the skill will develop. Now, what are the questions may asked by the patient? It is a page question. What are the causes of hepatomegaly? What are the causes of hepatomegaly? You should utter the common fast, common fast, like hepatomegaly. It is malaria, kalajor, then hepatoma, lymphoma, lymphoma, CLD. There are so many causes of hepatomegaly. What are the causes of tender hepatomegaly? Tender hepatomegaly, most tender hepatomegaly is due to liver abscess. You should tell fast liver abscess. Then you may tell about the CCF. You may tell about the acute hepatitis or hepatoma. Cause of hepatosplenomegaly. causes of hepatosplenomegaly. Hepatomegaly, splenomegaly. Common causeগুলো ফার্স্ট বলতে হবে। How will you differentiate secondaries from hepatocellular carcinoma? If sir, as differentiate secondaries from hepatocellular carcinoma, secondaries usually multiple. Hepatocellular carcinoma is usually single. There is amplifications. There is no amplification in the hepatocellular carcinoma. What is amplification? Amplification is the necrosis of the center of the tumor, necrosis of the center of the tumor, and it is due to decrease blood, this, failure to supply the blood in the center. So there is necrosis and there is amplification occurs. Hepatocellular carcinoma. And secondaries, there is you may find the other findings of the primary tumors. Investigations. Investigation. What investigation you want to do? I want to do ultrasonogram first of the hepatomedia system. Or what else? I can do a CT scan. I can do a MRI. Now, so when you ask for the hepatomegaly or palpate the hepatomegaly, you should discuss the findings properly. That it is 4 centimeter enlarged in the mid clavicular line, from the mid clavicular line to its lower border. Or now you can also measure the span of the liver by percussion of the upper border of the dullness. Don't forget to see the upper border of the dullness, because sometimes liver may drop down due to emphysema, pneumothorax, maybe drop down. So you may palpate the liver, but it is not enlarged. So you should see the upper border of the liver and see the liver span, and you you mention the length of the liver span. Usually 2.12.5 or 13 centimeter is normal liver span, and below above that it is said that liver is enlarged. What you want to do next, or what is relative examination? I want to see the spleen, as hepatosplenomegaly may occur so many diseases. I want to see, is there any ascites, malignancy থেকে হতে পারে, there is secondaries in the liver. So I want to see the primary causes of others. I want to see, is there any anemia, jaundice. These are the related questions and examinations. Investigations to already discussed. It is the how to detect the enlargement of the confirm the enlargement of the liver, and also the cause of enlargement of the liver or hepatomegaly. But there may be other investigations related to the diseases you mentioned. Now splenomegaly. Already, according to according to instruction, you will perform the examination. You will perform the examination according to the instruction, and for the splenomegaly. You may ask why it is spleen. Then you should answer why it is spleen. It is there is not there is enlargement towards the right iliac fossa. There is respiration. It moves with respiration downwards. So I think it is. So my diagnosis is splenomegaly. Why it is not not kidney, enlarged left kidney. Why it is not enlarged left kidney? You will differentiate, the why, how to differentiate it from kidneys. There is insinuation cannot be possible in splenomegaly, but insinuation possible in kidney. It is movement with respiration downwards. There is slight movement also in the kidney, but there is not. It is no notch in the kidney. It is rounded. So this is the how will you proceed this type of questions. And this splenomegaly, cause of splenomegaly তোমাকে বলতে হবে. You should know the diseases also. Suppose you uttered the um, the splenomegaly. What is the huge uh, splenomegaly? Huge cause of huge. If it is more than 15 centimeter, then it is it is a huge splenomegaly. And cause. What are the cause? The CML is very common cause of huge splenomegaly. CML, CLD, also in malaria, there may be huge splenomegaly. Huge splenomegaly also occurs in thalassemia, the hemolytic and congenital hemolytic anemias. So huge splenomegaly. How will you confirm that it is a congenital hemolytic anemia? There is microcytic hypochromic anemia. What investigation you want to do? Hemoglobin electrophoresis. So how this is how you proceed and how you ask the questions. Related malaria, there may be what are the species of malarial parasite. If you say utter, if you say that it is Kalajat, then the name of the uh, parasites of Kalajat. Causes of hepatosplenomegaly. Hepatosplenomegaly cause, you should get the common first. And what is it is not kidney. I also say and investigations according to your findings and according to your diagnosis, you should tell the investigations. But how to confirm, but how to confirm that it is a spleen, ultrasonogram, CT scan, MRI, anything else. Usually, ultrasonogram is enough to enough to confirm the diagnosis. Now, lumps in the abdomen. Lump may present in abdomen in any parts, the quadrants, and according to the presence of lumps at the quadrant, their related organs usually are the disease of the related organ is the cause of lumps. Then you again tell the findings. Be careful. You should mention this. You should mention this. Examine these points like site where it is. Is it epigastric? Is it right hypochondriac? Is it left hypochondriac? Is it in the right iliac fossa, lumbar hypogastrium? There you should tell size. Whatever the size, it is how much diameter. Usually we uh, measure it in diameter, centimeter in diameter. And shape. What is the shape? Rounded or elongated? Usually rounded, but sometimes elongated may be found, and it may be give you false. Sometimes in the hard stool may be found in the left iliac fossa region, sigmoidal region, and it may be uh, misinterpreted. So shape is important. Consistency. Surface is a rough. Usually malignant one has a rough surface. Fixity and mobility, fixed or mobile. এটা অবশ্যই দেখতে হবে. You should usually if it is fixed, it is It is possibility is malignancy. Mobile, it possibility usually not malignant. And the direction of the mobility is also important. Like in the hypogastrium region, one you find a lump which is hypogastric region in the midline. You found a mass which is mobile downwards, upwards, and another one is mobile side to side. This will help you and the patient is female. Then if it is side to side mobile, is possibility is it is a enlarged uterus, which is not move up and down, upwards and downwards. Then the tenderness means there is inflammation. There may be lump in the appendix due to appendicitis. It become tender, and it indicates there is inflammation. Infective causes may be the may the cause may be infection, and this is a site is very important. If it is in the right hypochondrium, then possibility, what are the possibilities? There may be, it may be a hepatic mass, it may be a gallbladder mass, it may be a mass in the right flexor or right of the transverse colon. If it is epigastric, it may be stomach, it may be head of the pancreas, it may be transverse colon in the mid portion. Left, there is transverse colon or spleen, or there may be. And if lumbar region, it may be a kidney, which is bimanually palpable. Right iliac fossa, there may be appendicular lump, there may be Crohn's, there may be tuberculosis of the ileocecal region. Left, there may be colonic masses. So when the lump is present, you should tell the findings like that. And what is your diagnosis? Question usually, as usual, questions. What relevant you want to see? What relevant you want to see? Like what relevant you want? And if, suppose I found a mass in the epigastrium. Then what relevant I want to see? I want to see the left supraclavicular gland. What is the name? It is the name of the supraclavicular gland. It is called Barthol's gland. So it is possibility is stomach cancer, carcinoma of the stomach. And then what I want to see other part of the other part of the body to see the any deposition of the secondaries in the secondaries. So these are the relevant. I want to see anemia in stomach carcinoma, in the carcinoma of the stomach and pancreatic carcinoma or any malignancy. There is anemia. There is anemia. There may be right hypochondriac mass. It may be the head of the pancreas, epigastric. It may cause jaundice with palpable gallbladder, jaundice with palpable gallbladder if obstruct the common bile duct, head of the pancreas. So I want to see jaundice. I want to see any scratch marks. I want to see any lymph nodes. So these are the. So how will you confirm your diagnosis? If your diagnosis is carcinoma of the stomach, then how will you confirm? I want to do an endoscopy with histopathological examination. Hello? So if your answer is it may be a case cause of it may be a case of carcinoma of the stomach, the investigation will be endoscopy of the upper GIT with investigation of the upper GIT with histopathological examination. If it is liver, then the investigation will be CT scan, MRI with biopsy to confirm the malignancy or other is with the malignancy. So usually these are the, and if it is a hepatomegaly, so CBC, then you can do a CBC. So the investigation will be according to your presentation. Now come to respiratory system. Important. The most common, most common, most common most common cases are pleural effusion, found in pleural effusion, then COPD, then asthma, pneumonic consolidation, bronchitis. COPD is more in the ward we found. Asthma relatively less found in the ward, as asthma patients not stay in the hospital for for long period, but COPD may have to stay in the hospital for a long period, and they are prone to prone to develop exacerbation of the disease. So they are presented in the ward more common. Now, proliferation, you may ask for examination from back of the chest. You should position the patient. You should position the patient. Patient may lying. Is there any? Can you reveal the? Can you uh, examine the patient from back? Then you should position the patient in the sitting position. Accordingly, you will position the patient. Then do the examination. If examiner asks for only percussion, you should do only percussion. Okay. Then proliferation. যদি আসি প্রয়াসী ইনস্ট্রাকশন ফাইন্ডিংস গুলা তোমাকে বলতে হবে এক্সিবিশন করে দ্য ফাইন্ডিংস গুলাকে অবশ্যই সুন্দর এবং প্লিজ ডোন্ট ফরগেট টু সে মেনশন দ্য সাইট মেনশন করতে ভোলা যাবে না হ্যাঁ নেভার ফরগেট we always forget to mention what is your diagnosis. My diagnosis is pleural effusion. No, it is left sided or right sided pleural effusion. Better tell the if you tell the if you tell it is huge massive pleural effusion, is it moderate pleural effusion or mild pleural effusion, at least please say the site. আমাদের প্রায় এটা ভুল হয়ে যায়। Now pleural effusion chest findings তোমাকে বলতে হবে what are the findings of pleural effusion যেমন in inspection there is restricted movement in the left side or right side, there is bulging of the spaces. In palpation there is asymmetry of the movement. There is percussion note is dull. When you say that percussion note is dull, then you should mention from space, from which space and downwards. Is it two intercostal space 2 and downwards, 5 or downwards, 7 or downwards? এইভাবে you should mention. Then the breath sound is dull. Sorry, breath sound is diminished or absent. Vocal resonance, breath sound resonance, vocal resonance decrease. And if you say that it is stony dull, then you will not able to you will not uh, permitted to give other uh, causes of dull percussion note like consolidation or musculation or fibrosis or collapse, because stony dull is preserved for fluid in the space, pleural space. So when you uh, say that the percussion note is stony dull, it should your diagnosis should be pleural effusion. Then you will say, what are the common cause of pleural effusion? First, you should say the common cause, like tuberculous pleural effusion, malignant pleural effusion, new parapneumonic pleural effusion, pulmonary infarction. Then you say the other cause of pleural effusion. Sometimes, sir also say, may ask you to, what are the cause of bilateral pleural effusion? Bilateral pleural effusion usually systemic involvement, and usually there is increased hydrostatic pressure. So what are the causes of increased hydrostatic pressure? Like congestive heart failure. If there is oncotic pressure, it is decreased hypoproteinemia. Then nephrotic syndrome, generalized. It is the generalized part of generalized pleural effusion. So these are the bilateral pleural effusion. Usually these are transudative pleural effusion. Then what is exudative pleural effusion? তোমরা জানি যে pleural effusion, exudative pleural effusion কাকে বলে? Then 3 গ্রামে, more than 3 gram per liter protein and cell debris rich fluid is exudative. Transudative, less than 3 gram per liter protein. But more appropriate is the, in case of pleural effusion, more appropriate criteria is the Light's criteria. Light's criteria of pleural effusion, exudative pleural effusion. Well, what is Light's criteria of exudative pleural effusion? It takes the part the serum albumin and pleural fluid albumin ratio. It is more than 5. Then LDH. LDH ratio more than zero point 0.6, zero point 0.5, zero point 0.6, and LDH more than two-third of the upper limit of the two-third of the more than two-third of the upper limit of the serum LDH. এই ক্রাইটেরিয়াতে যদি হয়, then it is exudative and more accurate. Bilateral proliferation cause malignant proliferation. What is sometimes malignant spread in the pleural pleura causes proliferation. Usually, there is a rapid formation of the pleural fluid, uh, and how to treat. Pleurodehiscus is the answer, and primary disease, treatment of the primary disease. How will you investigate the patient? Investigate according to your diagnosis. Suppose it may be a case of pulmonary tuberculosis with pleural fluid, with pleural involvement, tuberculous pleural effusion. Then you will investigate accordingly. CBC, where is high, yes, sir. There is lymphocytosis may be present, and sputum for AFP. Then pleural fluid study. Pleural fluid study দিয়ে আমরা কি কি দেখি? pleural fluid studyতে আমরা দেখি হচ্ছে তার physical test, physically, if it is hazy, if it is clear, or if it is reddish or white. If clear, transudative may the cause. If hazy, there is infection. If cloudy, or spider web when you rest it for a few hours, spider web, then it is tuberculosis. If reddish, if uniformly red, the pleural fluid is uniformly red, then it may be due to malignancy or and or if it is white, then it is a chylothorax, that is lymphatic leakage in the pleural cavity. Then biochemical test আমরা গ্লুকোজ দেখা হয়, পিএইচ দেখতে হয়, গ্লুকোজ ডিক্রিজ, it is the decrease in malignancies, pH decrease in malignancies, which is a bad problem. And then protein, then protein, yes, it will exudative and transudative, differentiate exudative and transudative. Then differential count. What are the cell present in the pleural fluid? Cell present in the pleural fluid is, if it is neutrophil rich pleural fluid, then the cause may be acute infection like parapneumonic effusion due to bacterial infection and parapneumonic bacterial infection. If it is lymphocyte rich, then it is maybe tubercular pleural effusion. If there is RBC, plenty of RBC, then it may be malignant pleural effusion. If this, and then cytology, if there is any malignant cell, to see any malignant cell, then we can do a AFB, gram stain and sensitivity, gram stain, culture sensitivity, and pleural fluid culture, PCR of the pleural, or gene expert PCR or gene expert of the pleural fluid, এগুলো আমরা করতে পারি। Then biopsy may give it is malignant or tubercular pleural fluid. Then sir, maybe how will you confirm uh, tuberculosis by doing a biopsy? If the biopsy have tuberculoma, then it is presence of tuberculoma, then it is tuberculosis. And malignant cell, if there is malignant cell, it is malignancy. This is how we proceed to proliferation. Then asthma COPD, several times you are in the lecture, you read in the lectures, and you read in the words several times, the asthma and COPD. It is usually what are the why it is not asthma, like question why it is asthma or it is COPD, যে কোনো কিছুই হতে পারে, যে how what if it is asthma, why it is asthma, because it is episodic attack, there is a history of allergy or eczematous lesions, there is family history, these are the, yeah, and there is history of relief by taking medication, eh? Rapid relief of uh, symptoms after taking medications. Why it is COPD? It is a progressive disease. The patient is a smoker. There is change in the chest, change, change in the chest. What are the change? There is recessions, intercostal recessions. There is a barrel-shaped chest. There is hyperactive accessory muscles of respiration, etc. So this way you will differentiate it. And how will you clinically differentiate COPD from asthma? Clinically differentiate, already you know. Drug used to manage asthma, COPD, asthma, bronchodilators, asthma, COPD, দুটাতে bronchodilators and inhaled corticosteroid with bronchodilators. Which one you prefer in case of COPD bronchodilators? I will prefer anticholinergic. হচ্ছে anticholinergic drugs like ipratropium bromide, tiotropium bromide, এগুলা asthma the salbutamol, formoterol, montelukast in case of asthma. COPD usually not needs montelukast, and other theophylline may be used. This is the how you manage asthma or COPD. Single question in a short you may ask. Maybe what is the if there is type 2 failure, what may be the examination findings? You may say the bounding pulse, there is pink and bounding pulse, warm periphery, and there may be papilledema present and flapping tremor present in case of type 2 respiratory failure. Type 2 respiratory failure, both oxygen and carbon dioxide increased in the blood. And asthmatic usually initially type 1, but when exhausted, it may be type 2, turn into type 2 respiratory failure. Type 1, what is type 1 respiratory? It is the saturation of the oxygen content of the blood is decreased, but carbon dioxide is normal. Now, what is corpulmonally? The definition may be asked corpulmonally. And if the COPD patient have leg edema, may not always suffering from corpulmonally, because due to retention of the sodium and water with the hypercapnic kidney, there may be edema without corpulmonary. Corpulmonary, there is concomitant hypertrophy with or without failure. Only hypertrophy may be indicate the corpulmonary. Failure not necessary. How will you make clinically diagnosed corpulmonary? This is right heart corpulmonary. Clinically, আমরা জানি যে we know that the left parasternal heave loud P2. This indicates the okay, pulmonary hypertension, and there is right ventricular hypertrophy by enlargement. So, if you found that findings, it may be corpulmonary. Comorbidities may present with COPD. COPD comorbidity due to COPD itself, disease, and due to risk factor. যেমন comorbidities একেবারে chronic disease, so there may be depression, there may be osteoporosis due to increased level of circulating circulating cytokines, osteoporosis, fat osteoporosis, ischemic heart disease due to smoking, ischemic heart disease. There may be carcinoma of the lungs, lung cancer also may be a comorbid condition with COPD. What is the spirometry findings of COPD? It is FeV1, V2, FeV1 forced vital capacity ratio less than 0.7%. And severity is done by the forced vital capacity. How the forced vital capacity affected? More affected, then more severe, less affected, less severe. But the ratio is always 0.7. Restrictive and obstructive lung disease. Restrictive lung disease when the compliance is decreased, and obstructive lung disease when there is airway obstruction. How will you differentiate it? By spirometry, you can differentiate it. What is the findings? Spirometric foundation, FEV1 forced vital capacity normal in case of restrictive, as simultaneously affected, and there is COPD, obstructive lung disease, there is reduced. The mnemonic consolidation, you know the consolidation, what are the findings? Fibroscope collapse, fibrosis, consolidation. These three. You should difference clinically these three. What are the findings? Clinical findings Examination findings of collapse, examination findings of fibrosis, examination findings of consolidation. Trachea position, very important, trachea position, rib crowdings, these are very important. But collapse, there is everything is collapse, so there is decreased vocal breath, there is decreased breath sound, there is breath sound, there is decreased vocal resonance, fibrosis, there is entry of the air, so there is findings of the consolidation, but there is trachea deviation is present and there may be crepitus, but consolidation have no crepitus initially, but in the resolution phase there may be crepitus. Investigation, chest x-ray, CT scan, HR, high resolution CT scan may be needed to see the also cause of the collapse, fibrosis or consolidation. What is the bronchial base sound? এটা তোমরা সবাই জানো what is bronchial base sound. Condition where bronchial base sound presents. Why is not pleural effusion pneumothorax? This is the differential by findings between this pleural effusion pneumothorax and সব ফাইন্ডিংস গুলা আমাদেরকে জানতে হবে when you examine the chest. Then bronchiectasis, maslation, all normal bronchiectasis এর cause গুলা তোমাকে জানতে হবে. You should know the cause of bronchiectasis. What relative you want to know? I want to know the cyanosis and I want to know that I want to examine the clubbing, maslation also. Is of okay, same questions. Rheumated hand examination. Okay, thank you. Next, I will try to. Okay, yes, no?